Hi, everyone. Thank you so much for tuning in. For those of you who are not familiar with me, my name is Kayla Smock, and I am the president and founder of the Occipital Neuralgia Foundation. I've actually been dealing with ON myself for about 8 years now, so I do have that personal and professional connection with occipital neuralgia. As far as the Occipital Neuralgia Foundation, we are coming up on 3 years of incorporation. Actually, next week, we'll hit our three-year anniversary. So as far as ONF, there are 3 aspects of our mission. The first being providing support to those suffering with occipital neuralgia, as well as their caregivers. The second aspect of our mission is to educate the public surrounding occipital neuralgia. And lastly, we strive to promote research into the causes and treatments of occipital neuralgia. That being said, we periodically do these virtual interviews with different specialists just to learn more about occipital neuralgia. So today we are here with Dr. Ivan Ducic. So Dr. Ducic founded the Washington Nerve Institute. He is a board-certified plastic surgeon and nerve expert, and he's also a clinical professor of surgery at George Washington University, and he actually served as past president of the American Society of Peripheral Nerves. So that's a little brief introduction. Dr. Ducic, would you mind explaining a little bit more about what you do and your practice?
Absolutely. Thank you, Kayla. It's really great to be part of this great discussion. You know, after such a great introduction, I better don't say anything else. We can just stop right now, right? In any event, you know, 20 years ago when I finished plastic surgery training at Georgetown and then nerve fellowship, I was looking into some new avenues how I can actually help patients related to complex nerve issues and presentations. And back in early 2002, 2003, I noticed one thing that caught my attention, how there was at that time, at least listed in the journals, about 180 different diagnoses of the headaches and migraines. And I said, oh my God, I never knew there are so many of them. How people actually address all of those complexities. And little by little, I kind of got intrigued in what is done for those patients, what is done for nerve injuries, and I kind of synced in literally into getting interested in this. And sooner or later, you know, my plastic surgery activities several years later got converted completely into the nerve surgery. So I'm now pretty much more nerve surgeon than a plastic surgeon.
That's great. And you were saying you've done roughly 4,000 of these surgeries, right? Regarding occipital neuralgia.
So almost, you know, it's going to go now 19 years or so. So there's a really very large population out there of patients with occipital neuralgia, patients with frontotemporal neuralgia, with chronic migraines. The little problem that I see out there, Kayla, is I think it depends from what specialist to what specialist you come. You might get a different diagnosis. You know, patients might present on Monday one way, but on Friday might have a different symptom. So on Monday they might get one diagnosis and on Friday the other. And I think that just adds a little bit more to the complexity of this.
No, definitely. So before we jump into our questions, I do just want to preface that throughout this video chat, we will be discussing a lot of information regarding occipital neuralgia. However, we are not in any way recommending specific treatments for ON. That's, of course, a decision that should be made between you and your physician. So that being said, given the name occipital neuralgia, we understand that occipital refers to the back of the head, neuralgia refers to nerve pain. But in your own words, what really is occipital neuralgia?
So occipital neuralgia is a medical condition where nerve pretty much presents itself as a protesting a compromise. So if you press the nerve, pinch the nerve, irritate the nerve, that nerve is going to first respond to the pain, and then after that is going to get irritated in the form of a neuritis, that is basically inflammatory condition due to constant rubbing as the nerve is being pressed and going through tight tunnels, either because of the abnormal anatomy or because of, you know, causative factors as traction stretch injury and the whiplash car injuries, hits, falls, previous surgeries in that area. All of them can offset the normal functioning of your nerve. And normal functioning of the occipital nerve, by the way, is to provide the sensation in the back of the head. So if somebody were to take their hands and put in the back of the head like this and cover that area, technically that entire posterior hemisphere of the back is basically innervated with the occipital area, with the occipital nerves.
Okay. And so you had mentioned that a lot of the times it's brought on by like car accidents, previous surgeries. Is occipital neuralgia always brought on by a traumatic event?
No, not necessarily. I would say in this past almost 20 years I've been doing that, probably about 60-70+% had some sort of the insulting event. Unfortunately, sometimes even repetitive one. Concussions, sports-related injuries and concussions, as I said, whiplash injuries, physical abuse, and in terms of physical, hits in the back of the head, people falling on the sports field, basketball, for example, quite often. Sports people getting nailed into their head with the knee of the other player or a cleat. So any one of these can just add and contribute to more. But I would say at least 35, maybe 45% of patients, really nobody knows exact numbers out there. It's just bad luck and abnormal anatomy that end up being the case after all of the other, potential, medical conditions were excluded.
Mm-hmm. That's interesting that you say that because we did a study back in May of 2021 to learn more about the onset of symptoms and how people came to their occipital neuralgia diagnosis. And we actually found, I believe it was 41%, they were not sure how their ON was brought on. So roughly the same numbers that you just mentioned. So how would one come to a diagnosis of occipital neuralgia?
So depending on the causation, it can be abrupt or it can be slow and slowly progressing. Usually, if there was a direct physical trauma, symptoms might be sooner than later. But let's say you have a bad whiplash injury. Just from a personal story, back in 2004, I nearly got killed with somebody running into the back of me, running 190 miles an hour away from the police on Sunday morning at 9 o'clock as I was going from my home to the office. And I have to tell you, I had myself occipital neuralgia probably for solid about 9 to 12 months. That's actually pretty difficult to function with the pain and all kind of other issues. So fortunately or unfortunately, I lived through this myself, so I can tell you, you can have a pain in the back of the head. So mine started very quickly. Some patients can start a little bit later on. You can have a pain in the back of the head. You can have pain radiating from the back of the head towards the side or top of the head. Patients can often say they feel like a pressure behind the eye or eyes. Obviously, any pressure over the nerves in the back can trigger the pain. Ladies more than men would say they have a problem combing their hair. For the record, men almost never combs their hair. Just kind of funny note. And patients can also say they have a problem resting the head against the pillow, called pillow sign. On top of this, and we can speak about other symptoms, I'll let you, in a minute or two, but this would be kind of like direct mix of occipital neuralgia type of the symptoms, neuralgia neuritis, that is localized to one anatomical area back of the head. If this condition is not recognized and treated in a proper fashion, unfortunately that can then escalate towards frontotemporal area, towards a migraine, and then you can have a fairly unpleasant mixture of the things where you can have sometimes more back of the head problems, sometimes more front and side, sometimes unilateral head problems, sometimes bilateral. This is what I said, depending on what symptoms patients can have on, 12 days of the month versus 7 days of the month versus 29 days of the month, wherever you are, the weather changes, periods, stress, all kind of other stuff, that picture can really go in a very waveform. So one needs to kind of, as a physician, zoom back a little bit and kind of look at the big picture where that patient is, rather than taking a snapshot of the patient and giving them whatever diagnosis that patient could be most likely.
Sure. So you had mentioned that eventually the pain could actually spread from the back to the front. Is that something, if your ON was treated properly from the very beginning, could that reduce the risk of it traveling or eventually becoming migraine?
You know, I always say to my patients that nerve medical conditions are like a roof leak. The longer it lasts, the more damage there is. So same thing is with this.
Okay.
Ideally, if the medical treatment would not be effective for at least 3-4 months or so, I think nerve surgery consultations would be useful, at least to put that patient on the radar, to define as an interdisciplinary approach between the neurologist and or pain specialist and the surgeon, because treatment of the occipital neuralgia patients or patients with chronic migraine headaches or even frontotemporal neuralgia has to be interdisciplinary. Any specialist who says, you know, my way or highway or I can do it all, unfortunately, with respect, doesn't understand the complexity. And this definitely has to be three-team: patient, medical provider, and surgical provider to be in sync if and when medical care should be supplemented with surgery or replaced with surgery. And that is not unilateral position, or at least should not be on anyone's part.
Sure. Okay, sure. I did want to thank you for sharing your personal story about dealing with occipital neuralgia. Thank you for that. And so going on to treatments, are there less invasive treatment options before pursuing surgery?
Of course. Look, surgery should never be first choice, all right?
Right.
And if anybody would be approaching occipital neuralgia treatment first with surgery, that should not be the case. Those patients should be very careful not to run under those premises, because sometimes surgeon can be just eager to operate. Patient can be innocently just following surgeon's directions, and sooner or later, situation can be frankly abused on patient expense. So one needs to look at that in a more frankly ethical way. That number one, before we get into the treatment, one needs to exclude, patients can have occipital neuralgia if they have a high blood pressure, you can have a high thyroid issues, you can have the glucose problems, brain tumors, all kind of stuff. So proper medical evaluation with medical provider is critical. Surgeon should not be the one first. I mean, you may or may not know, but people cannot even get appointment with me in my office if they had not had a previous neurologist or pain specialist, especially neurologist, evaluate them and clear this medical condition. Because if I were to operate on anyone, ignoring this other potential medical condition causing a problem, that would be huge disservice to the patient. So proper diagnosis is not only made based on patient complaints, then me verifying them on the physical anatomy and provocative tests that I can do in the office. And then after that, if these medical potential conditions are excluded, and it is really occipital neuralgia or neuritis, then medical specialists should take control over that patient for a few months. And I have to tell you, probably 60-75% of these patients might settle on their own. So if we were to operate from day one, that would not be good. Having said that, it is very important to observe that patient and for patients to pay attention how they progress or not progress with the treatment. Because if a medical treatment applied with best of the intentions and skills from medical colleagues, it would not be effective, and symptoms would be continuing, or patients simply cannot tolerate medications. 15% of Lyrica patients have hallucinations. That's tough, they can't function like that. So one needs to be very, observant to how people respond to medications given to them. But having said that, let's say they respond okay, but effect doesn't last too long, or the side effects are not really allowing that medication to really continue, then interdisciplinary care should be involved. And I would say that from that perspective, before any surgical consideration would be given. If the nerve surgeon evaluates the patient, needs to confirm tenderness over the nerves, needs to listen to the patient to confirm that that syncs with that, and also would need to ensure the diagnostic blocks are effective. And just to help clarify something, diagnostic nerve block is the injection that is being done in the office. So it is not like X-ray or operating room, just in the office. Like when people go to dentists, they numb their gums so they can work on the teeth. In my case, I'm obviously not numbing the gums, but I would go ahead and block the nerves in the occipital area. That would then give us information. If you chemically neutralize these nerves, then while the nerve block is lasting, patient should respond favorably to that in terms of saying they got a break. That would indirectly or directly, frankly, tell us that the nerves in the back of the head are involved as the generators of the pain.
Okay. So if someone has like successful nerve blocks, that means that they have some type of relief. It doesn't have to be 100% relief, just something. Is that right?
Yes, and just to put it in one more thing, patients can have, there are many patients, I remember one of the largest actually study to date I published back in 2009 had 243 patients. And I remember at that time when I was writing, the average time to presentation of those patients was 17.4 years. It is like unbelievable, duration of suffering. So that has a twofold meaning. Almost all of them said they had a pain 30 days a month, but not necessarily that every occipital neuralgia neuritis patient will have pain all the time. So you might, when you make appointment with me, let's say 17th of the month, you might have a good day that day. And if I do the block that day, we might not capture what we need to capture. So again, one needs to step back. I might need to bring the patient for second time or third time. And definitely if the nerve blocks after maybe 2 sessions would not be temporarily effective, then both patient and surgeons need to have a very frank discussion should the surgery be done. Because again, all the way back in that 2009 study when I published, if I looked at that time, patients I did not manage to help was I think about 18%. Every one of them had did not have a tenderness over the nerves or positive nerve block. And at that time, there was no really literature discussing that. So I started a discussion with that paper to alarm the doctors that if patient doesn't have tenderness over the nerves and doesn't respond favorably to nerve block, we might need to hold off on surgery and revisit maybe some other options.
Sure. Would you mind explaining a little bit more about the surgery that you're talking about?
Yes. So in a way, I gave you quite a few long answers to a fairly short question you asked me, but you asked me also, are there any other non-surgical options? So I will refer back that there are pain management treatment options and there are surgical treatment options. So study I put out in 2014 doing systemic review comparing these all three variables. So if you take the radiofrequency ablation that is done usually to try to disinhibit the nerves from actually providing the painful stimuli to the brain, radiofrequency ablation, unfortunately, that is like the before thermally and now with the pulse therapy with the needle coming close to the nerve that pain specialists do, recurs in about 50% to 100% by 3 or 6 months. So unfortunately, the duration of that is really not long-term. On the other hand, if you take the neuromodulation or nerve stimulators, that's like a pacemaker battery that can be implanted on the anterior chest or the flank area. I don't do that. It's the domain of pain specialists. And then wires coming down to the neck area, to the occipital nerves, and you stimulate those nerves, again, trying to disturb the painful signal going from the compromised nerve to the brain. So effectiveness can be about 70%. The issue with those is that about only half to 60% of them are still effective beyond 3 years. So unfortunately, duration is again not a long term. So the common to these two procedures, meaning radiofrequency ablation and neuromodulation, is unfortunately neither one of them is undoing the causation, and that is compromised compressed nerve, because physically they cannot. So the surgery, unlike these two procedures, you go to the operating room, you're placed with your face down in total anesthesia, and in about an average hour and a half time or so, you would go ahead and decompress the nerve. So what that does mean is, imagine I have a shirt and tie and I cannot breathe, and I said, Kayla, help me, because after whatever happened to my neck, etc., I feel like choking, I can't breathe or so. You will take scissors, you're going to cut my shirt and tie so I can breathe. So technically that's what procedure does. You offload the physical pressure, the tunnels where the nerves go through. This is not a brain surgery, this is not spine surgery, it's done in the soft tissues in the back of the head.
Okay. And would you mind talking to us a little bit more about like success rates regarding decompression surgery?
Of course. One detail I forgot to say, that I do not shave patients' head, just for the record, because this procedure can be done without shaving the head, and many patients actually were quite happy about that detail. But long story short, when I was starting this in early 2000, frankly, there were only a few years that this was out, and I had to learn my way around in a very transparent way, said, and do my best as a fellowship-trained nerve surgeon to try to make sense of this. So my first surgery was actually 35-year-old PhD student from Georgetown, whose neurologist said, listen, for 9 years, for several years, I've been dealing with this very motivated patient who cannot finish her PhD because she's in tremendous pain. And anytime she studies for a long time, her pain is killing her. So anyway, so that was my very first patient. And I told her at that time, please understand, you're my very first patient. I've done this in a full disclosure. It might take us longer. I'll do my best to take care of you. And I was for many years driving home, and I was admiring that woman, how much courage she had to do that, and how much pain and suffering she had to sign up with someone who had actually never done the procedure. So obviously, as a fellowship-trained nerve surgeon, I had some credibility with that, but still not particularly that. So in any event, that was the first time, and that took me 2 hours, I think, and 43 minutes. Now this surgery is between an hour and 30 and an hour and 50 minutes in my hand. Success at that time in early 2000 was about 80%, 79, 80%. This day and age is about 92 to 95%. But with that being said, I am trying to educate patients whenever I can, or colleagues, especially neurology colleagues and primary care doctor and pain specialists. Early referral is extremely important to success, because I'm a same surgeon, it's the same human body, meaning patient, and it's the same condition. So one variable that we can change is having these patients come early, because evidence-based data in nerve surgery have taught us the longer the duration of the problem and the more severe compression or nerve involvement is, lesser the outcome in terms of effectiveness. And that's a clean-cut fact from head to toe. So this is why I think anybody with these problems lasting more than 3 months, definitely lasting more than 6 months, should have a nerve surgery evaluation to try to help them in the best way. So indirectly, you might ask me, so what happens to the patients that you haven't helped? Why you haven't helped that, let's call it 10% or 7, 8, 9 or so. It is not that after 4,000 plus of these surgeries, probably closer to 4.5 than 4,000, I don't know what I'm doing, but it is rather, unfortunately, duration of the problems and severity of the problems that can internally derail the nerves to that extent that after I had my shirt and tie cut off and I'm expected to breathe, after, I couldn't breathe before because of the chronic compression, my neck and breathing might simply not recover, meaning that nerve, because of the severity of the duration of the compression. So speaking one more time, that earlier intervention might be more beneficial than the late surgeries.
Absolutely. So in the cases where decompression doesn't necessarily bring a patient down to like a level 0 pain, at that point of course you would have to discuss with the patient, but would another decompression surgery be an option? Or in this case, would different medications or prior treatments, would those help now?
When the surgery doesn't help, both patient and the surgeon need to take a hard stop, and they need to think through why it didn't help. Is there anything else potentially compromising patient condition? So in a way, I always step back and define as if I never met that patient again. Is there anything else? Other problems on the front and side that we might need to address in terms of frontotemporal neuralgia or migraines. Is the back of the head truly problem? Is the cervical spine evolving problem? So one needs to kind of set the clock back to make sure that nothing, I hate to say missed, but nothing is existing on the side that might do that. So let's say that is being done, and let's say that patient still has tenderness over the nerves in the back of the head, then I personally would perform additional nerve blocks on the patient, and in that case I insist doing it myself, although half of my patients are from across the country or elsewhere, but I would definitely request that I do those diagnostic blocks at that time, because then we are at the extremely important crossroad. If those patients are still hurting, they're still painful over the nerve exam, and they are responding to the blocks despite failed decompression, then my step in algorithm after that is to go back and remove the occipital nerves. And I need to clarify this. When you remove them, you also need to reconstruct the end, because nobody should just cut the nerves. Otherwise, nerve is going to grow into the scar and create problem. But if you microsurgically reconstruct the end, you prevent that. So the only study to date published about this, world is so small, is I think in 2014 study that I authored. And at that time, about 115 something patients ended up having surgery, not mine, but from all across wherever they found me. And I went back and removed the nerves. 72% of those patients basically were helped. So 2/3 can still respond to additional surgery with excision. Decompression, unfortunately, is not a wise move, because if it meant to help, and if it is done properly, it should have helped the first time. And if it didn't, repeating something that already failed, I think it's almost more of the disservice to the patient than help.
Right. Okay. That makes sense. Are there any risk? Of course, there's risk factors with any surgery, but could you talk a little bit more about the potential risk factors?
Of course. So first, proper criteria for surgery need to be met. Patient needs to be medically suitable for surgery. Cervical spine needs to be excluded if there are any cervical spine problems. ABC is what I called in terms of medical condition, brain condition, etc. needs to be excluded, because the biggest complication that can happen is that you operate on someone who actually has other than surgical indication problem, and then you bought them basically another problem. Aside from that, if that is being done in the right way, look, ABCs of any surgery is potential for anesthesia risks, bleeding, infections, and all of those things. If the surgery is done properly, this should be to bare minimum. As you know, anywhere in plastic surgery, if we cut from head to toe, and let's say you do 1,000 surgeries, about 2 to 3% might develop skin infection, just because how human bodies basically respond. That requires just extra week of antibiotics, and that's pretty much more or less. No cervical spine injury should happen, no brain involvement should be done, no other nerve injury should happen or vasculature, because you really have a very targeted target that you're after as a surgeon. There is no wandering around or exploration. It is like, tracing a flight from DC to San Diego, you need to know at every point what coordinates you're going to be at every minute or hour. And if that's in your mind as a surgeon getting into the operating room, then a perioperative risk should be bare minimum.
Sure, sure. Thank you for that explanation. We had a couple questions regarding whether or not people just whether or not their ON will go away on their own, or is some type of intervention always necessary?
First, it's obviously a very reasonable and logical question to ask because I'm a surgeon and obviously I try to help patients with surgery, but I'm at the same time first one to tell them surgery is not the first treatment to do, and if we can prevent from having surgery, that might be best. Unfortunately, by the time patients come to me, they already had diagnostics. They already have conservative measures. They have done all of these things. So at least I am stepping in when other things have basically failed from that particular end. As a rule of thumb, anywhere in nerve surgery, with the conditions that are slowly evolving, meaning it's not that somebody took a knife and cuts your nerve, then it's instant basically injury. People cut an arm with a glass and they have numbness or they can't move the hand. We know nobody's going to wait for 3 or 6 months. You need to kind of intervene right away. But with occipital neuritis and neuralgia conditions, they usually are either spontaneously evolving or they are following sort of the a traumatic event, and some patients can develop symptoms fairly quickly, some couple of weeks or couple of months later. So bottom line is, whenever symptoms started, if they are present for several months, I would say any time after 3, definitely any time after 6 months, patients should have a surgical evaluation to define if they can be helped or not. So that's what I feel, that there is about grace period of 3 to 6 months to see if they're going to spontaneously resolve. And obviously, if the patient is afraid of surgery and wants to wait longer, that is patient's right. Frankly, I as a surgeon am obligated to offer that to the patient if they feel they are not ready for surgery psychologically or any other way. No surgeon ever should push them to surgery. People have to do it on their own pace after they've been given proper education about it. Because what I see sometimes the patient tell me is that decisions of, 2 years ago when I've done the meta-analysis of all of the patients I treated, about half of them said to me they were never told surgery was the option. And about 70% or 75 or so, I forgot the exact number, said that they were referred late. So clearly sort of the miscommunication or misunderstanding or timing where interdisciplinary care from medical to surgical should be supplemented and gears switched. That axis, unfortunately, is not working on most of the nerve surgery from head to toe. And as much as lectures we give and everything, I think that's a sore spot, because if, let's say, somebody with diabetic neuropathy, they would be referred early for carpal tunnel or tarsal tunnel in the hands or feet for numbness or tingling or burning. And if I intervene on them early, I can save them from having basically loss of the sensation in the hands or fingers permanently. But if they are being referred 2-3 years later, my surgery might do nothing except torture them with the surgery or create basically complication or something. So there is a very precious window that needs to be acknowledged by all. And I feel that what you are doing, to be honest with you, it's incredibly important, because patients are seeking for proper advice. It is incredibly difficult for average patient to search on the ocean of the information at the internet, because everybody who is especially advertising or so, they might look they are geniuses, but they might do 2 cases, and patient might not have a good understanding of what the expertise and data is. So, having direct education to the patient, I think it's extremely important.
I appreciate that. Thank you. Yeah,
Absolutely.
it definitely comes from my own journey with occipital neuralgia, going back to the miscommunication. It was, I want to say, at least probably 3 years until I even knew that surgery was an option. And on top of that, it was another year and a half until I even had an accurate diagnosis of occipital neuralgia since the onset of my symptoms. So that is kind of like what pushed me to creating this organization. And it's great being able to meet with like different specialists to provide just like one concrete platform for people to learn more about occipital neuralgia. So thank you for that.
Absolutely.
So to kind of close out our call, I did want to ask you, what does the future of occipital neuralgia look like? Are there like different clinical trials being done that you know of, new advancements in medication, different things like that?
So I'm going to answer that in 3 different ways.
Okay.
I don't know if you have enough time for that, but I'll try to be concise.
Sure.
One, again, to give you credit, not because you and I are talking on this call, but I really truly to give you credit. Patients might not understand what you are doing, how much that is actually helping hand. That is truly helping hand, like that picture, helping hand. Same things with this. And all of us in life have a journey that, we get help from someone else, and then that someone else helps someone else, and that's how it goes. And I think that is incredibly important, that one avenue is that patients need to be educated in a very transparent way. There should be no biased choices. Even today, I said 3 times, surgery should not be done first time, okay? And I'm a surgeon saying that. So it's very important that also other colleagues are not going to just say to the patients, medication is the only treatment for you, and every 3 months you should just get medications, or that you should just get indefinitely 15 radiofrequency ablation and $50,000 nerve stimulator after that. And if you're just pushing that in one way, that's incredible disservice to the patient. So sometimes, it can be very difficult to say to other colleagues what they could or could not do, because who I am to tell other colleagues, what they should do. But the power of what you are doing is you're giving patient actually very transparent chance to actually learn and educate on their own, that there are different options for them out there. So one answer is patient education. 2, I'm struggling with that in 20 years of my professional career, how to actually integrate interdisciplinary care, how the specialist should communicate better. I have no clue. I don't care saying this publicly. I don't know if there is a monetary problem, if there is a pride problem that everybody wants to hold the patient from themselves. I don't know. But it is very clear in this day and age that one specialty cannot cure a condition. You need to have integrated team for that. And I don't think that huge number of colleagues out there are really grasping on that as a very important part, because that's the second avenue. Third avenue is even more painful and incredibly frustrating for me as a nerve surgeon, and that is complete arrogance and ignorance from insurance carriers. I think they are doing incredible disservice to the patient. I can't tell you how many very uncomfortable, almost heated discussions I have with medical directors of insurance company telling me, despite that medical treatment failed for years, despite that patient dropped out of the school or is getting divorced or is losing job or it's on depression already because of this condition, they are saying that surgery is experimental and they need to go back to their medical provider, do whatever needs to be done with them. I have no words to express how devastating is for the patient course of the treatment, because what happens with them, they are going to be only delayed with their treatment. As a nerve surgeon, I can tell you patients with chronic groin pain after hernia surgery, breast pain after mastectomies or so, knee replacement, extra head to toe, because I deal with these injuries from head to toe. Over 80% of the patients who have this chronic pain longer than 2 years have depression and anxiety. Every one of them almost. And then we are not dealing with one medical problem, meaning occipital neuralgia or neuritis or migraine headache or whatever other part of the pain. You're dealing with depression, you're dealing then with anxiety, because they're bouncing between how to live basically, because one day they're down, then you give them medications for down, then they go into other phase of the anxiety. And I have to say that literally as of like today, I had a discussion about one of the patients with medical director, and I've been told that their team had looked very diligently to define if this is experimental or not. Sadly, out of my 13 studies that I published on this subject, 6 or 7 of them are cited in there, and they are saying there are still not enough evidence, when evidence is out there for 20 years. So I'm going to be very rude and direct to say it is almost like somebody doesn't have incentive to actually help this patient because it's going to cost them money to pay for the treatment of that patient. We've seen that in 80s, when women with breast cancers were turned down for reconstruction because they were told that it's just aesthetic in nature and it's not needed. Today, luckily, it's law out there that every woman is entitled to get breast reconstruction after cancer because there are psychological reasons, there are all kind of reasons why that should happen. Nerve surgery, I think, is still lagging, especially headache, chronic migraine headaches, occipital neuralgia part, probably 10 years backward in insurance acknowledgement that this is a condition that should be treated in an interdisciplinary care, and surgery is an integral part of the treatment of these patients, because some things you can fix medically, some things you kind of need to take the brick and lift it off the foot because it's just pressing the toe. There is no medicine that can physically lift the brick off the toe. So I don't know how we're going to resolve this problem, to be honest, because literally it is, for me, becoming just sad, frankly, that these patients are being ignored to the extent that I ignored. So I kind of feel bad to end up this great discussion with this kind of down kind of part of the talk, but I think this discussion is important, and this information out there is important. People need to be aware that those who should be providing funding for their surgery should not turn them down, and then people need to pay out of their pocket and, go through all of that on their own. And don't forget, they have a pain to start with. They shouldn't have a pain because of the insurance issue. So I kind of, again, sympathize with the patients, and as a physician, I try to help whenever I can, but it's just a difficult tri-directional approach. Probably yours, educating patient, is the easiest one and probably most effective, but the other two in level of complexity, convincing all of the colleagues how to intervene on time, and then convincing insurance carrier they need to wake up and hear these patients because they are struggling, they're in pain, is even more frustrating. So it's a journey to be continued. I would strongly encourage you and your members to keep pushing. My practice is in DC area, in McLean, Virginia, and otherwise in Croatia, in Europe. Obviously licensed in both places. I'll be help whomever I can help, but I can't treat whole world, okay? So, everybody along the globe needs to kind of understand this concept, because I can comfortably tell you this is treatable problem in the vast majority of the patients, but needs to be recognized and addressed in a timely fashion.
Absolutely. No, I appreciate you explaining everything about the insurance battles, especially I think sometimes we forget that dealing with occipital neuralgia, a lot of the times we aren't able to actually go to work. So there's no means of financial income. So then we're supposed to be paying out of pocket for these different treatments, and that's not exactly feasible for many people. And I know something that I dealt with being a pediatric dealing with occipital neuralgia was many treatments such as Botox that wasn't covered by insurance because I was under the age of 18. So just keeping things like that in mind, and definitely continues to prove how important patient advocacy is for occipital neuralgia. No, definitely. Yeah.
That is awesome.
Yeah. So you mentioned that you're licensed in Europe, and then you're obviously based out of Washington, D.C. So if you are interested in learning more about Dr. Ducic, you could visit his website, which is Dr. Ducic, DRDUCIC, plasticsurgery.com. And again, this video will be posted to YouTube and to our social media channels. So Dr. Ducic, thank you again so much for joining us today, and thank you for sharing your expertise all surrounding every aspect of occipital neuralgia. It's greatly appreciated.
Kayla, on behalf of all of the prospective patients who may benefit from this, I want to congratulate you from doing this. This is spectacular, what you're doing, very important. So thank you on behalf of them. Appreciate it, and great to be tonight here.
Have a good day. Bye-bye.
Bye. Thank you, you too. Bye.